All right, hey guys, I posted an announcement, so we're gonna start at 9:45. You guys want to tell your friends? Did anybody have a difficulty opening the PowerPoint today? Okay. Oh yeah, I will in just a second. I just have to turn the room on.
Oh, true. Yeah.
These buttons on all this table is like really low. So I'm like the only one in. Oh no, Heather's in here. Somebody left the recording. Yeah, I know a few of them are coming, which is fine. So I would video this, but I told them I'd wait until 9:45 to really get started. So I'll give them a few minutes. Heather or Graylin, if you guys want to text the group and let them know that we're starting at 9:45 for the lab. I forgot to tell you guys that before I disconnected the meeting. So for like the comp, you guys are going to be sitting outside, and I have just the partners in each time, so no one's distracted. The only person that will be in here other than me is your partner. That's going to be your patient. So you'll go through like the whole spiel. Like I'll bring you in. You guys will pick whatever you're doing, and then you're going to pretend like that's your actual patient and be like, say you know her name already, or I'll give you like a fake name, and then they'll just say, yes, that's me, and like a birthday. So you'll verify name, date of birth, bring them in the room, confirm the exam that you're doing, and you'll still go through like, please remove all of your jewelry or like metal above your waist if you're doing a chest x-ray. If you're doing your abdomen, obviously you'd have them drop their jeans down or whatever metal they have around their waist, including their bra too, because usually the bra will show up. You'll have them do that, like pretend to do that, like don't take any clothes off the day of. And then obviously make sure you ask them if any chance they could be pregnant, especially for abdomen x-rays. We're x-raying the abdomen, we don't want them to be pregnant. They'll tell you no. And then we'll go on to the actual exam itself. And then you'll have 10 minutes per person. So
If you're doing abdomen, you have to take off.
no, no. So only in the affected areas. So from chest, so that's why you take your bra off, because your metal's going to show up, because you're going to get your diaphragm on your flat and your upright. And then you would remove like jeans, add jeans on, or any kind of like buttons, zippers, anything that's like in that area, they would slide it down. Chest x-rays, a lot of people ask that, like, do I need to take my earrings out too? The only time you ever have to take their earrings out is if they're like long and dangly, or if they're hoops. I always make them take their hoops out if they're big hoops, because when they breathe in, sometimes you'll see the hoops like hit their apices, and some people don't think of that. It's kind of like a learn as you go thing. So kids with glittery shirts and rhinestones, there's a lot of older women that like to wear rhinestone shirts, I've noticed. I'm like, you have to take that off, really? And I'm like, yeah, it's got rhinestones on it, so show up on your x-ray. So it's a great artifact. So, but I'm gonna wait just a few more minutes. In just a second. Yeah. Yeah. So today, after we go over like this stuff, you guys can split up, because last Tuesday some seniors came in and Mr. Graham wasn't here. He had somewhere else to be, and he emailed me, but I'm like, I don't check my email in the middle of like teaching. So all of a sudden I saw these like two random girls walk in, and I was like, you guys can join us if you want, because I thought it was like one of you guys from home, because I don't know everybody's faces and stuff. So they're like, no, we're good. And then I was like, I don't really know what's happening. Like, who are these people? So I went over and talked to them. They're like, oh, we're seniors. They gave us permission to be here. Mr. Graham gave you permission to be here. And I was like, oh, okay, like, we're going to change that. Because Tuesday is like your day with me. I can be here until 2 o'clock. Thursday, if he wants to let them come, it can be on his time, but after you guys have had time for lab. So they were here to practice. Yeah, because they're not able to go to clinical either. And then they have competencies coming up. So I told them, I was like, I know that they need to practice and have lab time, but like if you're not going to be here on Monday and Wednesday when that's their days to come to class, then you cannot let them come up here until after 12 o'clock on Thursdays, because I need my students in those groups to have enough time in the lab. And it was forced all 8 of them to be in this room the entire time because those girls were using the other 2. And I was like, hey, yeah, we're going to change this. This is not going to happen. Because you're not going to, like, I'm taking my free time to be here until 2 o'clock, and that was annoying. So. For what? Like, walk, like, you want me to actually, like, tell you, like, what we're doing?
Can you give us an example? Can I be your patient and show me what it's going to be like?
Yeah, so go over here. So, like, I'll take my name or, like, whatever I'm doing, right? Okay. So, your name's in the area. So, here, yeah. What is on your name? And your name's in the area. We're going to do chest x-rays today, correct? Sure. So, like, that's what your order would say. Make sure your patient knows what we're doing. And then I'm going to have you come in the room. Is there any chance you can be pregnant?
Absolutely not.
Okay. So I noticed that you have jewelry on. Can you go ahead and remove your jewelry? And if you have a bra that has any kind of metal in it, then just remove that for me too. So you don't actually have to take it off, but like pretend like you did. Okay. So you're obviously still wearing clothes. I'm going to have you come right over here to the board. You'll put your chest up against the board for me. Put your hands down by your side. Bring that stuff in front of you. Go ahead and step up real close to the board where you're touching it. And then I'm going to roll your shoulders forward. You stay just like that for me, don't move. And then I'd go to proceed to like actually detent the tube and all that. You guys actually want me to do that? No. Okay. Sorry for you guys at home. I'm giving them like a little bit of a practical stuff. So we actually determined that this is 72 as long as it's centered with this grid line right here. Like the ceiling tiles. There's a little mark. There's like a no. Yeah, that's no. I don't even. That mark is not even correct. I don't even know where that mark came from. But it's not 72 inches. So I would center her. She didn't move at all. Column 8. Drop just a little bit. So we're the 2 inches above her shoulder shadow. I'm going to detent. The last thing I'm going to move is this. Real life scenario, I would have a set in here to make sure that it's centered. Push it all the way in. She's good. Make sure her shoulders are still rolled forward. All right, Miss Joe, I need you to go ahead and take a deep breath in. Clear your out. Take a deep breath in. Hold your breath. Expose. Deep. We're done. Then you can go ahead and relax. We're going to turn so that your left side is against the board. Put both arms straight above your head for me. Need you to lift your chin up. Get real close to the board. Keep your chin up for me. And stay just like that. Don't move. Step forward just a teeny bit. Stay right there. Lift your chin up. Some patients will continue to like do not as you say. Just scoot out just a little bit. And then you can feel your back. Make sure she's straight. You don't really need to change the collimation on that, but you can open it top to bottom just a little bit and then collimate in just a little bit. Take another deep breath in for me. Clear your out. Lift your chin up. Take another deep breath in. Hold your breath. And relax. So on the actual exams, this doesn't have actual like something to hold on. You're just going to show me before you take your fake exposure. You're going to be like, this is where I'm going to shield.
Do they normally have like a Velcro or something?
Yes, I have no idea what happened.
It looks like there's like a thing that goes.
Yeah, I don't know how I got
where
where the belt went.
So that would have been on there.
Yes. So yeah, you would actually like before you start actually taking X-rays, or positioning her, I would just be like, I'm gonna put this on your waist, or I'm gonna hold this behind you, so you just wrap it around the front and attach it. So you would just show me on the actual exam, just be like, I'm gonna shield here, and then we'll go on to giving the breathing instructions and a big beep to indicate that that exposure is over with.
Would a thyroid shield be okay for that position?
No.
No.
Because we're doing chest x-rays.
I just thought like, like just there.
So, what's your arm size? It goes up, yeah. So you want it to about her rib line, to indicate that's where her, the bottom of her cross-front ankles would be. So, most people, you don't have to change, all you're changing is the collimation. You shouldn't have to change center. You're already centered at T7, you should still be centered at T7. So, and you can check, do that, like the roll like I showed you. You'll pretty much always be accurate. The only person that you have a complication on would be Ethan, who's like super tall. So you go down just a little bit, but you can use armpit line or visualize, like his nipples are probably like here, just kind of like visualize from the back. So, or you could have them put their back against the board first, mark at their nipple line, and turn it around. And then roll their shoulders forward. So. Yeah, just like show me, just be like, this is where I have a shield, Melanie, and then you'll go on to like giving the breathing instructions. Just tell me that you know where you're going to shield at. And then the shield will be like in the room. In an actual competency, like the cassette's going to be sitting on the table, and so is this. You guys can use my markers for the exam, or I'll make like a little paper one. I haven't really decided yet, but you'll mark the board too. Show me that you know where you put your marker and not in your actual X-ray field.
So mark left,
Yeah, yeah. So you'll definitely mark left for the lateral. You can mark right for the PA if you want, but you'll have to take it off and put your left up. So most X-ray techs, you always just put left on. You put like left for PHS and then just leave it up there for their lateral because you don't have to move it. So that way you don't have to remember, oh crap, the right's still up there, but that's left lateral. So. Make sense?
I don't have a question. So when she's, and then like the right side is facing the X-ray tube. So when you take the picture and the light flashes onto her, the image receptor is capturing this.
It's capturing the whole thing. So it goes all of our images are 2D. So it goes from this way through. So you're going to get right lung sitting on left lung onto the image receptor.
But it's for the left.
It is, because your left side is closer to the IR. That's why you're marking left side.
Right? It's left picture.
No, this one would be, like, the only place that they actually reverse the image is Baptist South that I know of, but most places where you take a left lateral, it would hang as a left lateral.
Okay,
Left
so
side
it's
down.
whatever side is closest to the receptor.
Correct.
Side that you're.
Yeah, so that's the same way with decubitus x-rays too, or like laterals, if like you're doing a supine lateral abdomen for some reason, or like when we discussed the fluoro stuff and like they're actually in a lateral and you're going from, again, like lateral to medial or medial to lateral, you'll mark side closest to the IR. Decubitus, the only difference is you're marking side, the affected side. So if we're looking at the left lung for air, the left lung is up because air rises, so you'd mark left side if they're in like a lateral like this.
And so the body part closest to the image receptor, that's what it like captured.
All of it does.
Not, I meant like the, because it says left, but is it all it's capturing?
It's the left side closest to the image receptor.
Okay.
Yeah. I didn't make up the rules, sorry.
Yes.
I know where your question's going, yeah. I didn't make it up. That's just how they want it.
You said lateral.
So patients like laying, right, like this. Yeah. So it depends on which lung we're looking at. If it's for a lung x-ray, like say we're doing a decubitus chest x-ray, are we looking for air? Your left, like say we're looking for air in the left lung. The left lung needs to be up, so you put them in a right lateral decubitus. If we're looking for fluid in the left side, we put then in a left lateral decubitus, because the fluid drops, is the gravity. So the gravity is going to bring the air up, the fluid will go down. So whatever side the affected lung or affected side of the abdomen is the side that you're going to mark. Does that make sense? Okay. So you would have to essentially like read, like you don't do decubes really ever, like I've done them like a handful of times, but you would need to know what the doctor's looking for. So if they're saying that they think there's trapped air in the left lung and they want a decubitus, you would put them in a right lateral decubitus and mark left side, his left side's up. Good? Okay, so this one's gonna be a little bit more difficult to video. Sorry for people at home, we'll do our best. So I need another chair or that chair, essentially.
I'm gonna grab another chair so I can leave the computer.
They might actually have to. Let's see what I'm doing. Everything's tabletop. So who wants to be the patient? Anybody? So we're gonna start with finger x-rays. So sit right here at the end of the table. So, yep, facing that way for me. And so you're gonna go ahead and put your right hand down. Let's say we're looking at the right hand. The only thing that we need to do, make me let me see the laptop. Make myself the presenter. Otherwise, this is gonna be really tiny. There you go. Yeah. Yeah, and then try to kind of face it down here. So we're gonna do her right finger. We'll do her index finger, for instance. So you do not have to be in detent for any tabletop x-rays. It's not necessary because we're not using the bucky. The only time you use detent is if you're using a bucky. So we're tabletop. So we don't have to be in detent. The only thing that we need to make sure that we are is that we're 40 inches tabletop SID. So make sure you focus on tabletop versus table receptor SID. So we're at 40 inches. We're doing her finger. So we're going to line up at her PIP joint, proximal interphalangeal joint. We're going to open the collimator to get a good majority of her metacarpal and then the top of her finger. So a good like section of it. You don't have to get all the way down necessarily because we're in a center right here at the PIP joint. So it'd be the same on all of these fingers. So this is your PA. The next thing that we would do is we turn her hand just a little bit. I'm going to turn your hand for you and just turn it just a little bit. Make sure she's kind of centered back on the red line. Come down just a teeny bit. So there's a little bit of OID here, her being in a 45-degree angle, but it's not severe. It's not going to make a huge difference. And then if you can put just your pointer finger out for me, and then I'm going to rotate your hand the opposite direction so that her pointer finger is flat against the surface. And then if it kind of pushes in like it did, just pull it back out. Again, we're doing it based on the patient's pain level too. So if they can't do it, then you can turn your tube to fit what we're looking at. But you don't have to change your collimation. Once your collimation's there, you're good. You shouldn't have to change your collimation. The only thing we're doing is making sure it's lined up and that everything is in the picture. All right, you can relax. Also, like we asked them to remove metal and jewelry for abdomens and chest, we asked them to remove jewelry on their hands. We don't want any hand jewelry. If they have, say we're doing a ring, like the ring finger, and they have a ring, and this old lady has been wearing that ring on her ring finger for 30 years, and she just cannot get it off because like her joints have fused around it, leave it on and just mark it, patient cannot remove. Just alert the patient like, well, we can't get it off and you don't want to take it off. Then if there's something underneath that, unfortunately the doctor can't read it. So it could change your diagnosis. So say there could be a hairline fracture, we don't know because we can't see it, depending on how thick the ring is too. Some people wear those like thick things and they get stuck. So, all right, so that's your hand. We'll do your thumb. Oh, sorry. So we will do the AP first. So I'm going to turn your hand for you. So we want her thumb flat against the surface. So all I did was take her from a PA rotate internally and flip it upside down. So now everything is flat against the surface. You'll center right at her interphalangeal joint, because remember, your thumb only has an interphalangeal joint right there in the center. And then just kind of turn her hand the best you can so you get the full thumb x-ray in there. So then we'll go on to her PA. Again, nothing's changing. Collimation, SID, everything stays the same. Don't touch anything. You're good. Like, everything's already been collimated. And then you'll flip her back over. Just relax your hand like a normal position. She's already in a 45-degree angle. We don't have to do anything. And then the last one, can you put your thumb up? And then we're just going to turn you on your side. Make sure she's in a true lateral. So make sure it's on her side and not just thumbs up, relax down, because then she'll get a 45-degree angle. So we want her in a true lateral. Everything is straight. Again, PIP joint, or interphalangeal joint, sorry. So right there. If anything, you could probably collimate a little bit tighter. You guys are new, but you want to make sure you have enough room to mark your image still. So, okay, you relax. So we'll do a hand x-ray. So bring your hand flat. So in this case, see how her arm is not completely flat against the table? You can raise the table so that everything is flat. You'll just open your collimation. SID still stays the same. We'll move this over to fit her hand. Make sure she's coming in straight. And again, you don't have to be in detent for these. So you open up just a little bit. And you can always ask them to bring their thumb in a little bit too, so you can collimate a little bit tighter. So you have enough to mark your film. Again, you're centered, MCP joint, third digit. Hands flat, everything's flat. Because if she's like this, you're going to create an angle at her carpal bones. So we do want to include her carpals. Her carpals would stop like right here. Got a little bit of ulna, a little bit of radius, a little bit of ulna. Then we'll do the 45-degree oblique. So rotate just a little bit. OID is fine, but her fingers are straight. Another way to do it is you can kind of pinch down like that. That's totally fine too, and acceptable. Can you go ahead and rotate your hand to the side and make an okay sign? Some people I ask them to make an okay sign and they're like, it's like struggles real with them. So we want to make sure that she's straight on her side, true lateral. So you want to make sure that these bones are straight right here. You will flare out her fingers. Just relax your fingers for me. I'm going to move them for you. Just communicate with your patient. Still hold them in a true lateral, and then just slightly separate these two fingers for me. And then you're in a true lateral. If you want to be super perfect, you just do it like that. But again, you don't want to collimate, because wherever your shadow's at, that's where your fingers are at. So don't collimate too tightly, because you cut that off, and then you cut off the tip of it. So MCP joint at the second digit, and then just slightly open, fan lateral. So you relax. All right, the last one is your wrist x-ray. You can do it two ways. The way I was taught, which the book doesn't really go over, is to make a fist with your hand so that everything is flat. That's putting the carpal bones as flat to the IR as possible, or you can have your hand flat out in front of you. And again, so whenever you go flat, it raises the carpal bones up just a little bit. So doing a fist is actually the better way to do it, because it puts everything as close to the IR as possible. It's not going to make a huge difference in your OID. It will magnify a lot. And on this, you can actually tightly collimate, because we don't care what's going on up here. Specifically, we're looking for is the carpal bones, but you do want to make sure you have enough collimation open to actually mark your film. So that's your PA. Go ahead and relax your hand. You're going to go into an oblique, so you just turn them just a little bit. Everything again is straight. You can move her over if you want to be real technical with it, or just have enough space for your marker. So that's your oblique. She's still at 45 degrees. And then go into, like you're making a karate chop with your hand. So that's the best way to get them real straight. And then you're going to take her wrist and just rotate it back just a little bit. That'll superimpose your ulna and your radius together. If you don't rotate, she's likely going to be slightly rotated here if you don't overly rotate in the lateral.
Are you doing that, like, assuming she's probably going to go back a little bit? Is that
That too, but also to get her in a perfect lateral. So there is some exceptions to like a lateral. You can be slightly rotated, but not so rotated that it looks like an oblique. So, and then go flat one more time. This is going to be for your scaphoid or your ulnar deviation. So we're going to rotate your hand. Let me do it for you. You're going to push to the ulnar side. Make sure she doesn't move too much. Your scaphoid is right in here. And for me, that's how tight I would call me as a tech. But if you guys, for comping purposes, you can do that. So you have enough space to leave a marker. That's totally fine. As long as you're showing me that we're just looking at this area, because I don't want to see all of the metacarpal and I don't want to see all the forearm. Good. They're really, like, extremities are super simple. PA, oblique, or oblique lateral. So, all right, good. Okay. So you guys can break up into groups and practice, or if you want me to, I can review chest and abdomen again with you if you need to.
Yeah.
Okay. Are you Kieran? Is that how you say your name? Kieran? Okay. You're like one of the only like 2 guys.
Yeah.
So.
Special time.
That's all I'm like, you review.
Yeah, you can go ahead and keep it on. So before you guys got here, we were going over chest x-rays. For the practical, ideally in the real world, you want to set up your cassettes to your patient's body habitus. So if they're real wide, you would do a crosswise chest x-ray. Most of you guys are tiny. Everybody pretty much can fit on this 14 wide. And we also, the pieces that you do use to adjust this board don't fit because this is a 14 by 14 cassette, not a 14 by 17 cassette. So it won't even sit in here correctly. Everything is off center. So for comp purposes, 14 by 17 upright is totally fine. You'll line up arrow to arrow. Everything should be centered right here. The only way you get that wrong is if you put the cassette in the wrong way. So you'll push it all the way in. If this board's not all the way in for your comp, that's points, because that could cause a repeat. Because you may be centered here, but this is not centered in there. You can put it down me. So wants to be a patient.
I'll go if you guys want to watch.
Okay, because Nicole was here yesterday, so if you don't mind. So go ahead and put your chest up against the board. You'll have already gone over, make sure you remove everything from the metal, waist up, make sure she's not pregnant, verify who she is, what exam we're doing. Always D10 first. So we're in D10, lights on. We're going to call this 72 right here. So we're going to center on this part of the panel on the ceiling. We're going to do 90. We're going to call your light on. I always start off really big. It's not going to hurt anything. Find your T7 for her. You can double check C7 to do that. But you write at T7 should be right along brow line, or you can also use armpit line. Nipple line should be the same thing from the front. You look so different today in like regular clothes.
Yeah.
So you want to make sure she's centered on her back. So it'll scoot over just a teeny bit right there. Make sure her shoulders are rolled forward and that she doesn't move on you. And then you'll collimate down to her body habitus. Right there is fine. And then I would just bring up the board as my last option. Just watch your chin. Everything is lined up. Red, red, red. And then that should put you about 2 inches. So you can check 3 fingers is totally fine. 4 fingers is fine too. And you can also mark left or right side. So I'm going to grab markers. I'll show you what they look like.
Are you guys gonna upload your videos? I don't know. Four's okay too.
These are my markers that I have this. So she stayed exactly where she's at, and then you do, I would just mark left side. It's in the light field, but not in her anatomy. So you guys can come around if you need to see that. a little bit better. It doesn't have to be straight up and down either. Left is left to the doctor. They know. So if it's on the side, they know it's left. And then, so you'll do your big exposure after you do this for 2 breaths. So take a deep breath in, pull your air out as you're walking away. Take another deep breath in, hold your breath, deep, we're done. So go ahead and translate your left side against the board. So put both arms straight above your head for me. Get real close to the board with your left side. And then have you scoot back just a teeny bit. And then make sure she's straight. You can check for scapulas, rotate her if you need to. She's just slightly off. Everything else is centered. It's okay to touch your patient. Your marker's still back here. The only thing I would do is probably move it a little bit closer because you're going to collimate from left to right. You can have it behind the patient. It's totally fine. You don't have to have it in the front. And then her collimation from top to bottom is still fine. She's still centered at T7, and I would just collimate left to right here. Nothing else changed. We didn't change the orientation of the board, so you don't have to even move the ball bucket at all. Right. Take a deep breath in, blow it out. Take another deep breath in, hold your breath. Deep. Okay, you can relax. So one thing you want to keep an eye on is that your patient's not swaying back and forth in the lateral. So to prevent that, you can just have them get real close to the board. Not where they're resting or uncomfortable. You don't want the patient to be in like a seat position. If some of these patients are wider, just get them as close to the board as possible. And there's also built-in handlebars on most boards in the hospital that are that they can hold on to. Or if they want to touch, some people don't want to. Some people can't lift their arms super high above their head because they've had shoulder surgery and stuff. So as long as they can get their arms up here, it's fine. As long as it's not in your chest anatomy.
Does it matter what are you doing that
For a lateral and PA. I mean, you could do a lateral first if you want. I mean, you're not going to get points off of me, but
it's probably easier to just do PA.
Yeah, because then you've already found your center, and all you have to do is rotate.
Melanie, this is running out of time, 7 minutes.
Okay. We'll give it like 5 more minutes, and then I'll shut it down and then reopen it. Okay. So, can you just minimize that? There, like. They got that like little box.
Where is it?
Yeah, there's an X on it. There you go. In a few minutes, I'll have to reset and then reopen the video. So, yes, yeah, face it to where it's under here. So we'll go over abdomen. A rule of thumb with abdomen x-rays, if you have an upright, do your upright first. Don't go to flat, because if you lie your patient flat, there goes all their air fluid levels. Upright first, because if you do flat first, then they have to wait till everything goes back to normal in upright. Most of these patients are sitting in their room, or they're sitting out in the lobby and that kind of stuff. So they've already been sitting upright. So the air fluid levels are balanced. So just when you come in the room, just go straight to your upright, then lay them down on the table.
How long would it take for like fluids?
About 15 minutes.
Oh, wow.
Yeah, so it's a decent amount of time. So, can you be my patient again, Nicole? So, your upright chest or upright abdomen is going to be the other one that we're going to do on the competency. We deemed this the 40-inch mark, so your tube's going to be in front of your black line. Your 40 inches. Go ahead and put your back against the board. We've already talked about all the metal. She's removed all the metal that we need. I usually try to move my bucky down to start with, and then I'll move it and adjust it later on as we get there. So I open all my collimators. I'm going to come down, center 2 inches above her crest. So you feel, sometimes you can feel the ASIS first, which is that bump in the front, and then you can just follow it up to her crest. So she's about right here, 2 inches above. You can just use your fingers, bring up just your vertical. Notice how I don't hit the all locks button or squeeze this handle. I'm already detented. I don't want to touch it again. So I've trained my brain not to ever touch those buttons again, unless I'm moving the tube out of the way for the patient. And you'll slide her over so she's centered. There you go. Put your hands down by your side. And then we'll just collimate left to right. And then we don't want bladder, or we don't need bladder on the upright abdomen. We only are really concerned about diaphragm, which we definitely got diaphragm because we're all the way up to her armpit level, and then just down to about like halfway through her wings of her pelvis. And then the last thing you do, make sure that this is centered. And the way I would mark, I have my left marker in my hand, but I would usually mark right. So bring her arm away from her a little bit. Her shirt is not going to show up on the x-ray. Sorry, that's your right side. You move her shirt out of the way because that's not going to show up on the x-ray anyway. And then just when she puts her arms back down, just bring your arms out to your side just a little bit so you can still see your marker. Because if her hand was like this, it'll superimpose your marker and you won't be able to see it. So everything is centered. You'll ask her to stop breathing. Blow all your air out. Stop breathing. Don't move. Deep. You're done. You don't shield. Yeah. Abdomen x-rays, you do not shield. So chest x-rays, you do not shield thyroid. Anybody ever asks you that, you do not shield thyroid. Yeah, so in this case, I would have given her a gown. If she would have come to me like this, I would have asked her to take her bra off and given her a gown to remove her pants. Because most people can't just drop their pants. Some people's pants will just slide depending on the kind of pants you're wearing. So just give them a gown. If they feel more comfortable taking all of it off, that's fine. It's not necessary. If they do, that's fine. You'll be surprised how many body parts you see years later. You can. I mean, it's really your preference, but as long as you're marking the correct lateral. So if you're in the left lateral for chest, you have to have a left. If you're a right lateral, then you have to mark right. So it's really determining the lateral, but you always mark that patient's side. So like I almost marked your right side, but it's the left side. So yeah, if you already have your left in your hand, it's fine, just use the left. If you have your right, use your right. You know. So you could also mark right on a PHS x-ray, but you'll have to remember to take it off and then put the left back up there when you're doing the lateral. So, all right, so we'll do the flat. If somebody doesn't mind keeping this on their lap so somebody can see it at home when I'm doing, sorry, you're in one picture. Again, we're not shielding. Go ahead and have a seat on the table. You're going to lay flat on your back, head down at the end. They'll ask you if they can take your shoes off. It does not matter. We're not looking at the feet. So bring the table up. I'm not going to break my back bending over to the patient. So the difference with the abdomen when they're laying flat on their back, we're going to take this up here. If you don't remember to take your cassette out of your left hand or your right chest, that's nice. You have to have your cassette, because if we took a real life exposure and you didn't have your cassette, guess what? You just exposed the patient and no image. So.
I have a question. What if we set it up first and then go back to that? Like we position.
Oh, that's totally fine. As long as you remember to get it in here before you say beep.
Before I say beep.
Yeah. I remember being a student and asking all these same questions, so nothing's a stupid question right now. All right, so everything is centered. We want to do crosswise first for supine abdomen. So rule of thumb for me, I always put this in the center of the table depending on body part. Like if I'm doing abdomen L spine, I'm going to put it in the center of the table. If I'm doing T spine, I'm going to put it at the top of the table. Because one day you'll run out of table and there's nowhere to go. And there's nowhere to go here, so then you have to be like, oh God, what did I just do? And let me see how I can figure this out. Without trying to move your patient, because your patient's in pain, your patient has fractures. Who knows what your patient's condition is? They could have just been shot, like if you work at Jan's, like who knows? So you don't want to move your patient. So I always do that first. Make sure that we're in intent. So push it till you intent for green light. You're going to bring it up to SID table receptor. So if you ended up at 40.2, I'm not going to ding you. Obviously, you know it's 40. It's okay. But I'm in D10, I'm at 40. I'm just gonna hit the long button so nothing comes out of my watch. Turn the light on. I always center this first, so that's, I don't have to worry about it. You can tweak this just a little bit if you want, instead of moving the tube anymore. Again, I open my collimators for centering.